Hey everyone, welcome back to another deep dive on the Explainer. Today we're jumping straight into a massive, absolutely crucial topic in clinical medicine, pneumonia. We're going to break this down for you with clear classifications, getting right to the core of the specific bacterial villains causing it. By the end of this Explainer, you're going to be able to connect the dots between a patient's history and the exact microbial culprit just by looking at the clinical evidence. It's like a giant puzzle, and we're going to give you all the pieces.
Okay, so let's dive into this. Here's our roadmap for today. We're starting with defining pneumonia, then the classification systems, gram-positive agents, gram-negative agents, atypical pathogens, and we'll wrap it all up with lung morphology and prevention.
All right, Section 1, Defining Pneumonia. Let's establish our baseline.
At its very core, pneumonia is the inflammation of the lung parenchyma, the functional tissue of the lungs, and it's triggered by microbial agents. But listen, the absolute key term you need to lock in right now is consolidation. Consolidation is literally just the presence of inflammatory fluid, or exudate, filling up those air spaces in the lungs. Understanding consolidation is the absolute key to grasping all the clinical symptoms and radiological signs we're going to talk about. Because when air gets replaced by fluid, it changes the whole shebang regarding how the lung sounds and exactly how it looks on an X-ray.
Moving on to Section 2, the classification systems, getting a macro view.
To properly diagnose pneumonia, we can't just view it as one single illness, right? We have to look at exactly how and where the patient caught it. Take community-acquired pneumonia, or CAP. If a patient walks in off the street with pneumonia, there's an 80% chance it's bacterial, with pneumococcus being the absolute heavy hitter. But if we're looking at hospital-acquired pneumonia, or HAPE, well, just by virtue of being in a hospital setting, the likely pathogens completely shift. We're talking notorious, often highly resistant bugs like Pseudomonas, Klebsiella, and MRSA. So honestly, the location where the patient contracted the illness, that is a massive, massive diagnostic clue.
Next up is the clinical presentation lens. So the crucial point here is how the symptoms actually kick off. Typical pneumonia, it hits you like a freight train. We're talking sudden onset, a high-grade fever spiking over 101 degrees Fahrenheit, severe shortness of breath, and a really heavy productive cough. But then you have atypical pneumonia, often called walking pneumonia, which is way sneakier. It has this insidious, slow onset, a lower-grade fever, and bizarrely enough, it brings extrapulmonary symptoms, things you wouldn't normally associate with your lungs at all, like severe headaches, muscle pain, nausea, and even diarrhea. Contrasting that sudden versus insidious onset helps doctors immediately narrow down the bacterial culprit.
Then, of course, we have the radiological lens. In lobar pneumonia, that consolidation we were just talking about is strictly confined to one single lobe of the lung. This focused, solid block of fluid is usually caused by typical bacteria. Now, contrast that with bronchopneumonia, which presents as this bilateral, patchy consolidation just scattered across multiple areas of both lungs. That scattered, patchy look, that is heavily associated with those sneaky atypical bacteria we just mentioned. And finally, doctors have to assess the severity, and they use this brilliantly simple, actionable tool called the KERB-65 score. You basically get 1 point for each factor: C for confusion, U for uremia over 7, R for a respiratory rate over 25, B for a systolic blood pressure under 90, and 65 for being over 65 years old. This score literally dictates the entire game plan. A mild score of 0 to 1, you get oral antibiotics and head home. A moderate score of 2 means admission to the hospital ward for IV antibiotics. But a severe score of 3 or more, no way around it. That's an immediate ICU admission with IV antibiotics and potential ventilation.
Okay, Section 3, Pathogen Profiles. Let's look at the gram-positive agents. Now we're shifting to our villains gallery, starting with 3 major gram-positive players. First up, pneumococcus. This guy is the undisputed king of community-acquired pneumonia, responsible for a whopping 50% of cases. It's especially dangerous for patients without a spleen, and its heavily tested clinical marker, a very distinct rusty-colored sputum. Another major offender is Staphylococcus aureus, which absolutely loves to strike post-influenza patients and IV drug abusers. Its unique signatures are a pus-filled sputum and a swinging, spiking fever with really intense chills. And rounding out this gram-positive group is Bacillus panthrix, a spore-forming rod. This is a major occupational hazard for cattle handlers and slaughterhouse workers, leading to what is historically known as wool sorter's disease.
Moving right along to Section 4, pathogen profiles for the gram-negative agents.
Now, what's really fascinating is the vivid color coding nature actually gives us.
Pseudomonas, for instance, is a leading cause of hospital-acquired pneumonia, especially in folks with pre-existing lung diseases like COPD. It notoriously produces this greenish sputum. Compare that to Klebsiella, another hospital-acquired threat, but this one favors the elderly and tends to attack the upper apical lobes of the lung. Klebsiella causes a dramatic, super thick, blood-tinged output that's known as current jelly sputum. And hey, don't forget Haemophilus influenza. While it causes a rusty sputum similar to our gram-positive pneumococcus, it's actually a gram-negative rod, and it often targets post-splenectomy patients out in the community.
All right, Section 5, Atypical and Special Pneumonias. Let's transition to the rule breakers. These are the pathogens that just don't play by standard rules. They read more like clinical mysteries. Imagine a patient who owns a bird pet shop and they come in with a patchy pneumonia. You should immediately suspect Chlamydia pisittaci, which is transmitted via aerosolized bird feces. Or consider a businessman who just got back from a hotel conference and suddenly has pneumonia accompanied by neurological seizures and dangerously low sodium levels. That is a textbook presentation for Legionella, which absolutely thrives in moist air conditioning plants. We also have Mycoplasma, this really bizarre bacteria with literally no cell wall that causes widespread walking pneumonia epidemics every few years, and it's marked by a positive Coombs test for cold agglutinins. And lastly, Coxiella burnetii, the cause of Q fever. This one can severely damage heart valves while frustratingly hiding from standard blood cultures.
We also have to highlight a very specific mechanical type of pneumonia, aspiration pneumonia. This happens when over 50 milliliters of fluid, or shockingly acidic gastric juice with a pH under 2.4, is accidentally inhaled right into the lungs. This usually goes down when a patient loses their gag reflex, so think stroke patients, folks having an epileptic seizure, or someone under general anesthesia. Because this brings up a chaotic, highly acidic mix of gut flora straight into the sterile lung environment, the pathogens involved are incredibly nasty. We're talking Pseudomonas, Klebsiella, and crucially, abscess-forming anaerobic bacteria like Bacteroides. This is exactly why the treatment requires a specific combo like ceftriaxone alongside metronidazole, just to make sure we're covering those dangerous anaerobes.
And finally, Section 6, Morphology and Prevention. So let's focus on what is physically happening inside the lung tissue over time. As pneumonia progresses, the lung actually goes through distinct morphological stages. First is congestion, where initial inflammation causes the blood vessels to dilate. Then comes this wildly fascinating stage called red hepatization, and this brilliantly illustrates how the body reacts. The massive influx of red blood cells and exudate literally makes the normally spongy lung tissue soft, solid, and red. It basically takes on the physical characteristics of a liver, hence the word hepatization. After that is gray hepatization, where the redness fades as specialized macrophage cells arrive, kind of acting like a cleanup crew, sweeping away the red blood cells and debris. Finally, if all goes well, we reach resolution, where the lung clears up and starts functioning normally again.
But look, rather than treating hepatized lungs, the absolute best medicine is prevention. Prophylaxis starts right after birth. Infants receive separate pneumococcal vaccines and the HIB vaccine for Haemophilus influenza at 6, 10, and 14 weeks of age. Now, for adults, boosters are required every 3 years, but specifically for high-risk groups. That means anyone who has had their spleen removed, suffers from COPD or chronic lung disease, is immunocompromised, or is dealing with end-organ failure. Protecting these vulnerable populations is for sure the absolute front line of defense against this disease. We've seen today just how specific the clinical clues can be, right? From owning a pet bird, to the exact color of a patient's sputum, to the specific lobe affected on an X-ray. Knowing the distinct profiles of these bacterial agents isn't just fun medical trivia, it literally dictates life-saving treatment. So I'll leave you with this thought. As we face a global era of rising aggressive antibiotic resistance, how critical will it become for clinicians to rapidly and flawlessly classify these infections on day one, before the wrong antibiotic is ever prescribed? Thank you for joining us on this deep dive on The Explainer. Keep analyzing, keep questioning, and we'll see you next time.